So we know the lung cancer, it is basically driven by the drivers as of today. There are so many genetic mutations there which we can target. So we know there are number of mutations which are there. And next one on the block is MET exon 14 skipping mutation, for which we now have 2 or 3 agents which are available. Earlier we had crizotinib, which was non-specific. Now capmatinib and tepotinib is there. So today we will be talking about capmatinib. So we know that NCC and guideline panel strongly advises broader molecular profiling with the goal of identifying driver mutations, even if they are rarer, because we know there might be drugs available for these mutations. And if it is so, definitely it is likely to give more benefit to the patient. So we know MET exon 14 skipping alterations can be found in 3 to 4% of non-small cell lung cancer patients. Of all the mutations, it constitutes only 3 to 4% of patients. But still, if we have any driver mutation, with targeting them, definitely we can prolong PFS and OS, and we can skip chemotherapy, which all the patients want. So this is the generalized schema showing different incidence of different mutations in non-small cell lung cancer in the non-squamous histology. So what is the importance of targeting MET exon 14 skipping alteration? We know it is an oncogenic driver. So how does this work? Basically, there is skipping of exon 14 in the genome. The 13 and 15 is there, 14 is skipped. So what it does is it disrupts the MET signaling pathway. We know it works in cohort with hepatocyte growth factor. So once there is loss of MET ubiquitation, so there is increase in number of MET receptors. So as they are not downgraded or they are not degraded, so there is increase in MET receptors. So these MET receptors causes increased signaling, which drives the oncogenesis. So then the question comes, how can we detect it? The MET alterations can be identified either by tissue or by liquid biopsy also. So this is another important thing when we see the data based on liquid biopsy. So the genetic material for molecular testing, it can either be obtained by solid tissue, which we all know and prefer, but we know at times it is not very easy to get the tissue. So at that point of time, there is liquid biopsy, and it can be sequenced by doing RT-PCR. And we know tumor cells release both circulating tumor DNA, cell-free and circulating tumor DNA, and that can be assayed to know the status of MET exon 14 mutations. So we have Garden 360, and we have other methods like Oncomine and tissue biopsy from doing the RT-PCR. So by doing the Garden study, we can come to know both about MET exon 14 skipping and amplification. Both of them are different things. As of now, the medicine is approved for MET exon 14 skipping mutations. So the specimen can be either plasma or frozen tissue, and in the RT-PCR can also be done in the pleural fluid or malignant pleural effusion also. So we know that the patients who harbor these mutations, the MET exon 14 mutations, they have a poorer prognosis as compared to the standard of care therapies. The standard of care, we clearly know the chemotherapy does not work much in these studies. So if we use the conventional chemotherapy in these patients, the likelihood of median OS is close to only 1 year. But if we target these with the respective medicines, the OS can be prolonged to as long as 5.5 years also. So we know the patients who have MET exon 14 skipping mutations, it can significantly improve the survival outcomes as compared to the chemotherapy. We know the chemotherapy gives a modest benefit of about 8.1 months. But if we target the same patients with the respected targetable drugs, the median OS can improve to 24.6 months, which is almost 3 times that of the chemotherapy arm, which is highly significant. So we also know that the patients who express PDL1, who have this exon 14 skipping mutations, they also express PDL1 expression. So immunotherapies versus this targeted drug, we know if the chemotherapy or immunotherapy was used in the real world analysis, it did not work that good. The median PFS was just 2.7 months if the conventional therapy, either immunotherapy or chemotherapy, was used, and median OS was just 12.3 months. As compared to the exon 14 targeted therapies, the PFS reached up to 15 months and OS improved to 30 months, which is quite significant, almost 2.5 times that of the standard therapies. So coming to the MET inhibitors, there are two types of MET inhibitors, type 1 and type 2. So fine differences we'll not discuss. So the MET inhibitors are either 1A or 1B. They are specific to the U-shaped UTP binding site. So the tepotinib, capmatinib, savolitinib, and AMG 337, they are all MET specific. Crizotinib, we know, is MET non-specific, and it works in ALK and ROS. That is 1A type, other all are 1B. The type 2 inhibitors, they are non-specific. They work on multiple tyrosine kinase inhibitors. So the more the target, it is covering the more likelihood of toxicity. And the tepotinib has been assessed in the largest study of its kind. Approximately 8,000 patients were screened, of which 7,000 was the liquid biopsies and 2,000 were the tissue biopsies. And about 337 patients had some form of MET abnormality. 313 patients had skipping mutations and 24 had MET amplification. The study was done across 150 sites in 15 countries, and they were basic idea is that the data was robust and it was done in wide variety of situations and circumstances. So Vision was a single arm phase 2 study. Few of the cohorts have been analyzed, and we know the results are there. So this study was done in the patients who harbored MET exon 14 mutation, and the criteria were standard criteria. They need to have this MET exon 14 skipping mutation, and the mutation can be there either on tissue or liquid biopsy as well. The previous the other trial which was done for probably capmatinib, it only had tissue biopsy, tissue-based mutation should be there. But in this study, they had used liquid-based also, and they had shown effectively that whatever be the method of we can choose, it is effective. So all the lines were approved. The prior immunotherapy was also allowed. The first line, second line, third line treatment was approved. The cohort A had about 152 patients, and they had the patients who had primary analysis was done. Once they were sure, yes, it was working, the cohort C was analyzed, was included to know the confirmatory analysis. They had 123 patients there, and who had more than 3 months of follow-up. So combined cohort A and C, they had close to 275 number of patients, which was quite good. And tepotinib was given in the dose of 450 milligram per once daily. So there were two cohorts, treatment naive and previously treated. The primary endpoint was overall response rates, and the secondary endpoints were duration of response, PFS, OS, and safety. So Vision was designed with the clinical practice in mind. We know that tissue is not always easy to get. So they had included liquid biopsy. We all know the advantages and limitations of both the methods. But here, the liquid biopsy, if the mutation was there on liquid biopsy, even then the patients were eligible. So this was prospective study, and it defined 3 analysis sets for all endpoints. Basically, they analyzed data based on all the subset where the patient had positive mutation on the tissue, when the patient had mutation positive on liquid biopsy, and the combined population also. So we, again, this study had large number of elderly patients. As MET exon 14 skipping is quite common in elderly patients. So median age was approximately 70 plus, 72.4 months was the median age. So most patients were elderly and even older in the first line setting. Male and female, approximately equal distribution was there, and half had a smoking history. And most patients, they had adenocarcinoma, And the squamous histology was also there, but it was in less number of patients. So if we look at the results here, so in the first line setting, there was overall response rate was 56.8%, and in the combined cohort, in the first line, and disease control rate was there in patients who were in 83.8% of patients. And the duration of response was again very impressive. If the patient had responded, the median duration of response was 46.4 months, and median progression-free survival was 15.3, and median was 25.9 months. If we look at the second line setting, again the same. There was some fall, 56.49%, some decrease in second line in the response rates, but still it was effective. Disease control rate somewhat lower as we expect as we go down the lane, but still impressive results. There was some fall in median PFS and OS also, but still it was quite impressive. So the tumor showed consistent sensitivity to tepotinib therapy regardless of line of the therapy, whether we used in first line or second line, it was efficacious. In cohort C patient in first line, the overall response rates were close to 60%. And in second line, it was close to 47%. Though it was not, the duration of response was not reached in first line, it was 12.6 months in the second line. Median PFS again 15.9 and 12.1 months in first and second line respectively. So the tepotinib demonstrated robust and lasting efficacy in treatment-naive patients who had MET exon 14 skipping mutations, which were detected by tissue biopsy. The overall response rate was 56.8%, which is quite impressive. And again, median duration of response 46.4 months, which is like quite impressive. And PFS of 15.3 months and OS of 25.9 months. So coming to the another big question, the patients who have brain metastasis. So this crosses blood-brain barrier, and it again there were 43 patients in both cohort A and C, and who the 30 patients had received prior brain RT or surgery. In patients with non-target lesions, the intracranial disease control rate was close to 88.4%, and with intracranial median PFS of 20.9 months. And in patients with target lesions, it was little lesser, but impressive results in terms of disease control in the intracranial. And if we look at the majority of patients from Asia, only 6 patients were outside the Asia, rest all were from Asia. And again, the median age was 71 years, which is quite an elderly population. And smoking history was there in approximately 40% of the patients. And the 34% were treatment naive, and 66% were treated previously. And about half the patients were detected on liquid biopsy. 37% and 72% had both tissue and liquid biopsy. So this was predominantly Asian study. So we have Asian data here. So if we look at the data, the efficacy in the treatment naive patients and the previously treated patients, it was consistent whether we had checked the mutation as per the liquid biopsy or the tissue biopsy. The responses did not differ much in the treatment naive patients. In the previously treatment, again, the liquid biopsy was as efficacious as the tissue biopsy specimens, with equal disease control rates and approximately similar median PFS and 12 months PFS, whether the stratification was done by liquid biopsy or the tissue diagnosis. Again, the OS was similar. It did not depend much upon the type by how it was detected. So if there is a benefit, the next question comes as the side effects and the cost. The tepotinib, it is usually generally well tolerated across lines, but there are treatment-related side effects, and there were few discontinuations. We know with the MET amplification inhibitors, the most common side effect is peripheral edema, which increases as the age increases. Probably there are a number of theories why this happens. One is because of the dysregulation between the MET and the HGF, which leads to vascular permeability, and it causes edema. So that is one theory why it happens, but the exact mechanism no one knows. But in the patients who have met exon 14 skipping, they have more edema as compared to the amplification patients. So any grade of side effects were there in 90% of the patients, but more than grade 3, only 30% patients had. And patients required dose reductions, and most common was due to the peripheral edema. It is there with other MET exon 14 amplification targeting drugs also. The temporary discontinuation was there in 40% of the patient, and permanent discontinuation was there in 14.1% of patients, and 4.5% was because of the peripheral edema. So peripheral edema is the main risk which is there. As I said earlier, the exon 14 skipping tend to have elderly population, and as the age advances, the risk of peripheral edema also increases. So it is more with the exon 14 skipping mutation as compared to the amplification. So as the age increased, the incidence of edema, peripheral edema also increased. So quality of life was maintained during tepotinib treatment, even in elderly patients. And the patients experienced mild cough, dyspnea, and pain, which probably was there because of the edema. If we compare different MET inhibitors, tepotinib, it is a highly selective MET inhibitor. It will compare the half-life. It has the highest T half-life, 32 hours, as compared to capmatinib of 6.5. And if we look at the brain penetration, very good brain penetration with tepotinib as compared to capmatinib. The crizotinib we know is non-specific. It works on different kinases and can result in toxicity. And both, they are highly selective. Both are type 1B inhibitors of MET tyrosine kinase inhibitor, and it is highly potent drugs. So because of the T half-life, it is the dosing is only once, and less number of tablets is required. So just dwelling on the doses, as a long half-life is there, 450 milligram once daily dose is required, as compared to the competitor drug, which requires more number of tablets. So it is simple. So there was unmet need. So basically, this is simple once daily oral dosing regime associated with robust efficacy and maintained quality of life. And with this, I'll say thank you. If there are any questions, we can discuss now, or we can take them in the next panel discussion. On this, thank you very much.
Thank you, Dr. Sumit, sir, for that excellent walkthrough about the role of tepotinib in the management of metastatic MET positive non-small cell lung cancer, for bringing out the importance of tepotinib, as well as how do we use and also safety profile of tepotinib and vision trial in a nutshell. Thank you again, sir. Do not see any questions in chat box, so I hope we'll move on to the